So ladies and gentlemen, the next speaker for the day is Dr. Udatta Kher, a very well-known speaker and personality in the implant field in India. Dr. Kher graduated from Government Dental College and Hospital, Mumbai in 1990 and followed that up with a master's in oral surgery, also from GDC. His main focus in practice is towards implant dentistry and is a visiting professor at STM Dental College, Dharwad. He is the study club director for the Mumbai Seacoast Study Club of the International Team of Implantology. He's also a registered ITI speaker. He's the director of Impart Education, an academy for guiding and nurturing clinicians towards evidence-based dental practice. He's an expert on Dental XP, the largest portal for dental education in the world. Today, Dr. Kher will be speaking on socket shield, myths and facts. Ladies and gentlemen, Dr. Kher.
I need the slide changer. The slide changer. Column F is not. Why is it going off? वो रिले जा रहा है वापस. It's here.
HDMI port is not there.
HDMI port is not there. This was working some time back. I just tested it. Yeah, slide changer I need. No, there is no the attachment. No, this will not fit. ये नहीं जाएगा इसमें. No, that's not the one. No, it's not about the slide. What is this? No, now they got it, I think. They got it. Huh? I've given it over there on the pen drive. It's copied there. Huh? Then use it. Connect that. I don't mind. I copy it and give it. No, Udatta Kher. No, connect this to that. Tell him to start that one. Got it? Now, which slide changer is going to work on this?
1 minute.
It works?
Yes.
Good. Okay. Sorry for the late start. There was some issue again with the audio visual. Once again, before I begin my Heartfelt gratitude to the ISOI for having me over again for a presentation this year. This is really daunting to speak after a great orator like Salah, who comes and introduces such a revolutionary concept. And I'm going to be speaking of yet another revolutionary / controversial topic that's going to be on socket shield technique. Now, this is something which has gained a lot of interest in the last few years, and the more and more we see of it, the more and more we are intrigued about how it can possibly work in our practices. So yeah, thanks for that introduction. A little bit about where I come from. I come from Mumbai, the vibrant city with a lot of chaos in it. And the last few days, it's been really underwater, I think. And but that's how it is. I've been born, brought up, studied, married, and working in Mumbai for the last so many years. And I've been practicing over here at this location. This is how it looks on Google Map. Those are just some few images of where I practice. This is my workspace where I spend all my professional time there. This is a bit of the declaration. I speak for a few companies, and I would thank BioHorizons and Katara for managing the logistics for me to come over here for this particular presentation. What I plan to cover today and what I plan to speak is understand the problems pertaining to alveolar ridge resorption, discuss the solutions that we have so far in achieving good aesthetic results and how to avoid this alveolar ridge resorption, with particular emphasis on the socket shield technique. So what exactly is the problem? What are we really discussing over here? The problem to start with is what happens when we extract the tooth. So the day the tooth gets extracted, we know that this little piece of bone over here, this small piece of bone known as bundle bone, is extremely vulnerable to resorption. And irrespective of what we do, this bone is going to resorb. Let's not fool ourselves. This bone is going to resorb, and it will resorb more if it is thinner. So that's the reason why when we are talking about the anterior maxilla, where especially in our Indian population, we see that this little piece of bone is so fragile, so thin, that from the day we extract, the resorption process begins. And it's a matter of time before that resorption increases, and as that little piece of bone reduces in dimension, what also reduces is the soft tissue that covers it. And this is exactly the problem that we are dealing with. What is the outcome of that is you might land up with a horizontal kind of a deficiency like this. You might be lucky if the patient does not have a high lip line and does not complain about any kind of an aesthetic issue if you land up with this kind of a situation. But that's not what always happens, because more often than not, what you land up seeing over a period of time is this, where a significant amount of the labial bone is lost. And it's a matter of time before peri-implantitis sets in, and matter of time before threads get exposed, and you start having all kinds of aesthetic nightmares. So these might be relatively minor, the ones you see over here on the top, but the ones you see down here are significant. These are significant that most patients, even with low aesthetic demands, are going to start complaining about these kind of situations. So having known what the problem is, what have been the possible solutions? So over the years, if you actually look into what we have been doing over the years, there have been three significant methods of I would say, avoiding or countering this kind of bundle bone resorption. One of it has been socket grafting, the other dual zone grafting, and early placement with contour augmentation. The first of the lot is socket grafting. We've been, all of us have tried socket grafting in our practices, and we've tried it with different types of biomaterials, different types of blood-derived products. We've tried all kinds of flaps, but somehow, and this is almost universal, that this is not very predictable. Whatever we have tried has never been so predictable that, after doing a graft, going a few months down the line and trying to enter the site, we are never sure whether we are going to be able to maintain that width of bone for us to be able to go and place implants without another round of grafting. More often than not, we see that whatever effort that we have put into doing socket grafting usually bounces back. Over the years, we used to believe once upon a time that if you were to extract a tooth and put an implant into the socket, there's a high percentage chance that you will not have any kind of resorption. But that's not true. Irrespective of whether you put an implant or you don't put an implant into that socket, you are definitely going to have that little resorption that's going to take place. And what happens typically is that once that resorption takes place and you start seeing soft tissue defects, around it, this is typically what you will end up with. These kind of outcomes are highly, highly undesirable, particularly in patients with high lip lines. One significant technique to try and counter the resorption of the bundle bone is this technique of dual zone grafting, where at the time of implant placement into the extraction socket, we would be using some kind of a slow substitution bone grafting material in order to compensate for that bundle bone resorption. So the bundle bone is going to resorb, but this slow substitution material is going to actually counter or compensate for that little resorption that's going to is likely to occur. And this has actually yielded very, very promising results for us in clinical practice. Another technique by the ITI group where they recommend that for any aesthetic case, if you want to minimize the risk, is do not try and place implants immediately in the extraction socket, whereas extract the teeth and go in and do an early placement between 4 to 6 weeks. Along with a contour augmentation, again with a slow resorbing material. Now, we have been doing this technique quite successfully for a few years, and I must admit that we do get very, very good results with this. But at the same time, this does require a significant amount of skills to be able to get that implant in place, do a good amount of grafting. And at times, I must admit that we have struggled in achieving those fantastic results that we sometimes see in textbooks and the books and the journals, even with an early placement protocol. In the last few years, what has really changed significantly for me in my practice has been this technique, that is the socket shield technique. This is one significant way in which I've been able to manage to preserve the ridge and at the same time try and manage and preserve those soft tissue contours that we want around those implants. I was introduced to this technique coincidentally during an ISOI meeting about 5 years ago by one of your local clinicians over here, Dr. Narayan, who happens to be a dear friend of mine, who was at that time just exposed to this technique. And during the ISOI meeting, in the evening, we had a bit of a brainstorming session and we had a discussion about it. Initially, of course, my thought process was to just, it sounded so absurd to me to leave a part of a tooth and place an implant behind it. So I kind of we discussed it over a period of time, and then I thought, no, this is something interesting, I must go and try it out. And very soon after that, I went and tried out a case, which I will show you shortly, which really changed the way I've started approaching any extractions that I do in clinical practice these days. Regarding the names, there have been various names. This technique has been over the years in literature called, has different terminologies. So one of the earliest names was the root membrane technique by this Greek group, which was, which have been doing this technique for a little over 10 years now. But what we really popularly known it is the socket shield technique by the German group of Herzler, Zur, and Baumer. This is the one that we are, popularly calling the socket shield technique. And then the group from the United States, the Salamas and Gluckman, who now call it the partial extraction therapy. Principally, they all pretty much have the same philosophy. It's just that over a period of time, certain protocols and certain techniques have been evolved, and based on that, even the names have changed. For the sake of simplicity, I will stick to socket shield as a term during this presentation, because that's a term that I think most of us over here are quite familiar with. Coming to the actual technique of how it has to be executed, let me try and demonstrate this to you with the help of some visuals now. So let's assume this is a tooth that needs to be extracted. Of course, you're not going to extract a healthy tooth like this, but assume it's a root piece that we are going to be extracting. You start off extracting maybe the coronal part of the tooth. Okay, so that's a pretty straightforward cut and extract the coronal part of the tooth. Most of the cases, we'll start off probably at this as your starting point. The key over here is to be able to take a long shank burr and create a cut which is going to section the tooth in such a way that you will be able to divide it into a labial and palatal fragment. And the key again over here is to be able to extract that palatal fragment without disturbing the labial fragment. And this, ladies and gentlemen, is the key to the success of this technique, is how well you will be able to extract that palatal part of the root without even slightly mobilizing the labial part of that root. So once that is achieved, the next step is to try and achieve this little bit contour over here, which is again very important not to leave any sharp edges around it. Once that's done, you will be able to create this kind of a contour for that little root piece that is stuck to the labial bone. And this will also give you a sufficient amount of restorative space for your final restoration. Now, what exactly is happening over here, if you realize this little piece of bundle bone, which is normally very prone to resorption, we are actually cheating nature here. The fact that this little piece of root remains over there, attached to that little fragile labial bone, along with the periodontal ligament, prevents any further resorption of that little bone on the labial side. So in a way, what we are actually doing is that we are cheating nature. Nature is presuming that the tooth is still intact over there, so the resorption process hasn't really started. And what are we doing after that is keeping that little root intact, and we are going to be placing our implant palatal to that, which actually happens to be the most prosthetically driven position in any case. Even if you were to place an implant without doing a socket shield, this would actually be the most prosthetically driven position for an implant for us to restore it effectively. So nothing much has changed. Instead of having a graft over there, which is going to compensate for that bundle bone resorption, what we are leaving back over there is a piece of, a healthy piece of root piece, which is stuck nicely to the labial bone. So that's how, in a nutshell, the technique is all about. Let's get into a clinical case, and I'll try and demonstrate the same technique in this case. This is a situation, this is the starting point where we had to extract this, this root piece. That's how it looked on the radiograph. So we start off again with a Longchamp carbide burr on a high-speed handpiece. This is the initial section that you do. Again, very carefully separating this root palatally and labially. Once that's done, using really fine-tipped elevators, we try and luxate out the palatal fragment, very carefully extract it. And of course, the best way to actually execute this is if you're able to extract the entire palatal part along with the apex of the tooth. Okay, leaving only that labial part of the tooth intact, then in fact most of the job is done if you're able to get the roots out like this. But unfortunately, that's not how the root always comes out. Sometimes our sections do not go exactly in the same line that I showed you in that illustration, and we'll end up going somewhere towards the apex or maybe somewhere a bit towards the palatal. Irrespective of what eventually happens, the key again for long-term success is to be able to get that apex out. So even if you've taken a small part of the palatal fragment out, what you need to do is go back in, using again Longchamp drills, and try and make sure that you've taken the apex out, because that's where you're probably going to have some amount of disease, and you do not want to leave any of that before you place that implant in. So the key is to get that apex out. Once the apex is out, then you're ready to go ahead with it. Now what you should also do is make sure that after you do this, you take a radiograph. Typically, most of the teeth that you will treat will be endodontically treated. They will have gutta percha inside. So it's very easy for you to understand whether you've actually eliminated the apex or not. Because when you take a radiograph and you don't see any gutta percha on it, you know that you pretty much eliminated the apical part of that root. How much of the root should be left is a question that normally gets asked. So the typical length of the root would be approximately 2/3 the length. So assuming that the 1/3 of it, which is the apex, is eliminated, the remaining 2/3 is what is kept. And once that's done, we need to trim the shield down. So again, using some football-shaped diamonds or round burrs, you trim down the shield and get it almost all the way down to the bone level. Once that's done, the shield is further thinned out so that you keep it maybe about 1 millimeter to 1.5 millimeters in thickness. Now this is the area where this part of the socket is where we are going to place our implant. So the shield thickness approximately 1 to 1.5 millimeters. Next, we are going to start our osteotomy to place the implant. That is typically going to be our point of entry, which is going to be the palatal bone. That's the initial drill that goes in. That's going to be the direction of the drill more towards the palatal side. That's the final drill, and that's the implant that's getting placed in. That's what you want to see at the end of the implant placement. So again, the key to success are 3 things over here. Number 1 is how well you shape the shield. Number 2, the gap that you will leave between the shield and the implant. This again is a key for success. The reason being, you do not want the implant to have any kind of pressure against that shield, because the moment the implant exerts pressure on the shield, the next thing you know is that the shield is going to get mobilized. You may not realize it while placing, but it's only over a period of time you may realize that the shield has got mobilized. And if the shield gets mobilized, then your case from there is going to go downhill. So your protocol should be to try and keep a gap. That gap might be minimal. It might be a millimeter gap. Optimum may be about 1.5 millimeters, I would say. But even about a millimeter gap where the shield is not touching the surface of the implant is what you want to see. The other thing that, the positive thing about it is that if you have that little gap, over a period of time, you're going to have bone filling into that gap. Okay? There's nothing else that will fill into it other than bone. You're going to have bone into that gap between the shield and the implant. The next key is, of course, to get the implant in the most suitable three-dimensional position, which is going to make your restoration look very pretty in the end. So no compromise on how the implant position has to be. It has to have the correct three-dimensional position. Another key to success is the primary stability. Typically, most of these cases that we will do a socket shield, we will go ahead and restore those cases immediately. For that, we need to have a high level of primary stability. So getting a good primary stability for the implant again will be key to success. So moving ahead with that case, what we would do after this is place the implant, fit an abutment onto it, modify the abutment, make a screw retain restoration, and then place that screw retain restoration on the day of the implant placement. The advantage of that is, of course, your contours are going to form very beautifully around it, and this is how it would look on the radiograph. The day you place the implant, you see a little bit of the shield over there poking out from the sides. That's the contour of the provisional restoration. And this is a real pretty picture. This is what you want to see before you go ahead and restore the case. When you take that provisional out, this is the kind of tissue and this is the kind of bulk you want to see over there on the labial side. So what do we have over there? We have soft tissue, we have bone below it, we have a part of the root below it, we have bone below that again, and then you have your implant. So that's that's the amount of bulk that you really have over there labial to this implant, and then from here on, of course, the case gets restored. I've shown you photographs of one case, but nothing like seeing a video because if a photograph speaks 1,000 words, I think a video speaks 10,000 words. So this is a case, again, a central incisor root piece had to be extracted. This is how it looked on the scan. That's the pre-op situation. So you start, the first step is to section the root. This is again on a high-speed drill. Using a long shank drill, you section the root. After the sectioning is done, the palatal part of the root is elevated with fine-tipped elevators and then gently extracted. Yeah. So once it's extracted, as you can see in this case, it's not the entire length of the root. It's only a small part of the palatal root that's come out. So what you do next is again take those long shank drills and cut back into the root so that you make sure that you eliminate the apex. Post that, take a radiograph, confirm that the apex is eliminated, and then use round burrs protecting the fragile soft tissue over there with some kind of retractors, and prepare the shield down almost up to the bone level. The next step is to prepare the osteotomy site, again on the palatal wall. In fact, I think this case allows using the denser drills. So again, just another application of the denser drills to get better primary stability for your implant. That's the implant that's being placed there. Again, no compromise on the position. The position has to be three-dimensional. Good primary stability again. And that's the gap that you want to see. So the gap between the implant and the shield, that again is the key to success. There's just a temporary plastic abutment that goes over the implant. Using some temporary restorative material, fabricate a chairside provisional. Insert that over the abutment. Wait for it to set. Once it sets, just unscrew the provisional and take it out. And now the next step would be to fill in that gap between the restorative margin of the abutment and the rest of the provisional that you have picked up. A good, nice finishing and polishing to be done so that in the end, when you take the restoration out after a few months, you want to see that really nice contour. This is how it looks on the radiograph again, a nice position for the implant. That's how it looks immediately on the day we do the procedure. Now let's come to some questions that are frequently asked about this. The number one question is, what is the fate of the shield? And that's always asked. And like I said, the way the technique has evolved over the last few years, there's no doubt in our mind that if the shield is left intact at the time of extraction, it's going to stay there. All right. And the fact that we are trimming it down now almost up to the bone level, we are actually seeing good amount of bone not just growing palatal to the shield, but also above the shield. and that helps in protecting the long-term stability of that shield. But like I said, these are still early days. We really don't know what's going to happen to it over a long period of time. What I can talk to you about is just medium term. But this is something which we are going to see very soon, maybe perhaps by the end of the year. This is a publication that's going to come up. This is just the initial image that I managed to see, is a close approximation of an implant against the root of a tooth, which was actually unintentional. But I don't know how they managed it, but they managed the human histology. So what you see over there is a human histology of a tooth, root, and closely approximated with the implant, and what you see over there in between is actual bone. Okay, so even when there is almost no space over there between the implant and the root, you are seeing bone, and I have no doubt that if there's ever possibility of doing more histological studies where you have a little space between the implant and the root shield, we are going to see more and more bone over there. So fate of the shield, still I would say we really don't know for sure, but whatever we've seen clinically, it all looks extremely positive. Next frequently asked question is, do we graft that gap? Not necessarily, at least in my practice, I do not graft any of those gaps. I know a lot of clinicians like to graft. Like I say, it does no harm if you graft, but if you want my personal opinion on this, I just don't graft any of those gaps. The next question is, should the implant be immediately provisionalized? Again, it's best if you provisionalize because you will get those wonderful contours from the day you place the implant. Alternately, you could actually leave it with a customized healing abutment, or maybe just a wide healing abutment, and then re-enter that site if you're not feeling very comfortable to do any kind of an immediate restoration over that implant. But yeah, it's not necessary is the answer. And the next question is, do we have to place the implant on the same day? Right? So you can also stage your implant placements. You don't necessarily have to go ahead and place the implant on the day you do the shield preparation. Right? And this is something which I would actually strongly recommend a lot of young clinicians who probably want to get started with this kind of a technique, is not to try and do both the things together of preparing the shield and putting the implant in on the same appointment. In fact, try and stage it so that you can, the whole process is not too intimidating for you. So that's a technique again which has been popularized by Glocker, known as staged socket shield technique, where what we would do in a typical case like this, where a premolar needed an extraction, is you do the same technique, you section the root. In this case, the palatal root is extracted first. Following that, the labial root is trimmed down, the apex is removed, the shield is prepared. Post that, this is how it looks on the radiograph. You make sure there's no gutta percha anywhere. The apex has all been eliminated. That's how it looks on the day of the extraction. Now from here on, if you feel comfortable, go ahead and place an implant. If not, like in this case, what we have done is just left some kind of a collagen plug, allowed it to heal, allow soft tissue to close, re-enter the site in about 4 to 6 weeks. Go ahead and place that implant in ideally prosthetically driven position, get your primary stability. Again, no need to be in a hurry to load that. You can leave it with a healing abutment, just a couple of sutures around it, allow it to heal. This is how it looks on the radiograph. This is just a provisional, which is like a Maryland, not loading the implant. You wait for the implant to integrate. Once the implant is integrated, then you go ahead and make an impression of that, and then go ahead and restore it with a simple screw retained restoration. But you see over here in the staged approach also, what you have achieved is that you are going to be able to maintain this lovely labial contour, which again is not very easy for us to do if we are extracting the entire tooth and trying to place an implant and maybe a graft to go with it. That's how it looks post-operatively. That's how it looks on the radiograph. So just a piece of advice for some of you who find the technique a little intimidating is just break it down into two. Don't necessarily go ahead and do the implant placements on the same day. There are a couple of contraindications, and I'm going to list 4 absolute contraindications to the socket shield technique. Number 1 is a mobile tooth. You don't do this on teeth which are mobile. Like I said, the key to the success is an intact, firm labial shield. And if the tooth is mobile to start with, there's no way you're going to be able to get any successful outcome. If there's no labial bone, again, you can't do a socket shield technique. So for that, to take a CBCT in all these cases is almost mandatory, because if you don't have labial bone and you trim the shield down from the palatal side, that shield is going to get mobile and you're going to land up with a failure. Again, when you have large periapical lesions like this, it's avoidable. Though, of course, these days we are kind of pushing the envelope and trying to do cases even with slightly larger periapical lesions. But as of now, I would consider it to be a complete contraindication. This is not a case that you would want to attempt a socket shield, either staged or immediate. Another contraindication is a tooth which is not in position. So for instance, if this lateral incisor, which is actually labially positioned, is not an ideal candidate for a socket shield technique, you would rather extract the tooth, let the bone heal, and get the implant placed in a more favorable position to have a much better outcome. Coming to the complications, these are the usual complications. One is a loose shield. If the shield gets loose, like I said, then you're literally going downhill from there. So that could be one of the intra-op complications, or maybe a delayed complication. Another very common complication is an internal exposure of the shield. So this you will know only after you remove the restoration. So after you remove the restoration or your healing abutment, you will see that a part of the shield is exposed from the inside. And if that happens, all you need to do is just take a burr again, just trim that shield down and make sure that you have tissue growing over it. So managing this complication again is not a very complicated surgical technique. Another complication that's likely to occur is that your shield is intact, okay, but your implant has failed to integrate. That may happen because of overload, because of whatever reason, the implant may fail to integrate. But you know what, the best thing about this is that even if the implant fails, there's nothing much that happens because the labial bone is intact, the shield is intact. Get the implant out, wait for it to heal, and just re-enter the site with another implant. That's all you need to do. Because your labial bone is intact over there, there's going to be no collapse of the ridge. In a way, this has actually acted like a shield for you to prevent any further collapse. So failure of an implant in the socket shield technique is a complication, but it's one of the easiest complications to deal with. Few advantages of it in terms of morbidity. This is perhaps one of the least morbid procedures that I've seen. You're extracting the tooth partially, you're placing the implants, you're not raising big flap, there's no major surgical work over here involved. The post-op recovery of all these patients is absolutely fantastic. And like I said, even if there is a complication, the complications are relatively so easy to manage compared to the complications that we have with some of the other conventional techniques. Another huge advantage is the soft tissue. I mean, the day after day when I start seeing some of those cases, I am getting more and more, convinced that, there's very few things that we have in implant dentistry right now that can match up to the soft tissue contours that can be achieved with this technique. So this is a case of a lateral incisor, which, as you can see, had internal resorption. We did the same technique, just extracted the tooth, put the implant after doing the socket shield preparation. This is how it looked after it eventually healed when we take the provisional out, and this is the step towards the final restoration. That's a zirconia abutment, and that's a lithium disilicate crown. Restored by a friend of mine, Saisha from Mumbai, and you can see the kind of soft tissue that you see around it. I mean, I know it's possible to get this kind of soft tissue around implants, but I know we've worked really, really very hard to be able to get anywhere close to that kind of soft tissue effect around implants using any of the other traditional methods. This is my first case. This is the case that I did after that little chat with Narayan 5 years ago, and this was the central incisor. And trust me, in those days we didn't have the instrumentation, the right kind of burrs to section it, the right kind of burrs to shape it. Didn't know about the concepts whether the shield should touch the implant, not to touch. But yeah, this was the first case, and I did it way back in 2013. And this is how it stands as of January 2017. That's a photograph that I took in January earlier this year. But again, like I'm trying to tell you, is the kind of soft tissue that you see over there. It's almost impossible to say where is a tooth over there and where is an implant. The one over here in the center is the implant, and the two adjacent teeth, two crowns next to it are the natural teeth. And if you actually see the tissue around the implant, it kind of looks healthier than what you see over there on the natural teeth. Please don't get me wrong, I'm not suggesting that you extract natural teeth and do socket shields and all, okay? This is just to compare that, the kind of tissue that you have is almost what you see around natural teeth. Another advantage that we see hugely is adjacent teeth. Yeah, to have two adjacent socket shields and to see the kind of tissue that you get, not just on the labial of it, but even interdentally, is something that we have never achieved, predictably in any of our traditional techniques wherever we have extracted. How many minutes do I have? 2 minutes, okay, yeah. Yeah, so these kind of contours, this is something that, we see more and more. This is again a case that Ali and I did together. We extracted those 3 roots, we got those 3 implants in. And again, beautifully restored over here by Ali. You know, this kind of contours in 3 adjacent implants is very difficult to get. And yeah, so that's how it looks, especially this kind of labial emergence that you see and the labial root you know, elevations that you see around these cases is just quite unbelievable. So something that Ali and I have been working together, we've been working on these adjacent implant cases, and we you know, in the process of compiling our data, and something that we hope to share in this consensus meeting over here in November in Madrid. So Ali and I would be presenting some of our cases over there during this Madrid conference, and of course, Salah, it will be great to have you over there again. Coming to the end of my presentation, I'll probably take last 1 minute just to show you how we're pushing the envelope. Now, this is not something that, again, I would recommend somebody who is starting off to do this. But like I said, you know, once you taste success in clinical practice, you want to just push yourself and try and do things more and more and more. And that's what I've been doing in the last year or so. So whatever you see this is just in the last 1 year or so that I've been doing. I rarely extract teeth completely these days. So especially in the maxilla. I don't do much of it in the mandible, but most of the extractions are all partial extractions with immediate or staged implant placements. So I've not stopped with the central or lateral. We go to the canine premolars and all the way back to the molars. This again is an example of a molar socket shield, the same kind of protocol. You can see the drastic difference over there in the first molar site where you know, extraction is done, and you see the amount of resorption that has taken place, and you can very well see what's going to happen over here as I follow up this case. So this is again restored. You can see the molar over there with the socket shield and the canine. I think I have the last 2 or 3 slides. Yeah. Pontic shield, another great advantage of a similar technique. Now in this case, we had to extract these 5 anterior teeth. Instead, we do socket shields in all of them. And the middle one, which is actually going to be a Pontic, we do not extract the whole tooth. We just leave a thin shield over there. And what that's going to do is going to again prevent the collapse of the labial plate. Is going to act like a shield over there. So you can see the implants are in the adjacent roots, in the adjacent sockets, whereas this is just going to help us maintain that architecture of the Pontic site. Something again that, like I said, pushing the envelope, I've gone to extremes of doing things now in the last year or so. This is a case where I actually did multiple socket shields and a Pontic shield with some osteodensification in one full arch case where we had to extract all the teeth. This is how the prosthesis looks. We provisionalized that case and went in and did the final prosthesis. And this is an immediate post-op. This is a case that I finished last week. I was just hoping I could take like a 1-week post-op of this and come and show it to you. But hopefully sometime, somewhere, you will be able to see a nice follow-up of this. The tissue still looks like, you know, it's slightly inflamed. That's because of the provisional that I took off from there. But what I'm trying to get to over here is the kind of possibilities that exist for us with this technique. So to conclude, so the socket shield technique, at least in my opinion right now, is the most predictable way of maintaining the labial bone and the soft tissue around implants, provided the technique is done correctly. The procedure is minimally invasive, has very, very low morbidity, minimal complications, complications which can be easily dealt with. It reduces the need of biomaterials, which I think in our country is a huge, huge benefit for us. We know the kind of, you know, costs that biomaterials are for us in our country. So if we can reduce the amount of biomaterials and yet try and get the same kind of results, I don't think there's anything better than that. The medium-term results are great. I agree there is no long-term data on it, and you know, the data is building up. There are more and more clinicians across the world who are presenting their data. It's a matter of time before we come up with it. So till now, it's fine to call this experimental. I'm quite happy to call this technique experimental. There is still no evidence, and I don't mind standing on the podium and saying that still the level of evidence is low. But what we see in clinical practice is extremely encouraging. All right, it's not a fad. It's not something which is going to just go off. Okay, it's going to be here. It's here to stay. But the last statement is the most important statement of the whole presentation. Okay, it's not for novice surgeons. Please do not attempt it. If you do not have the skills, if you've not done sufficient number of immediate extractions, provisionals, all kinds of different techniques before you have come and started doing the socket shield. So please take this as your take-home message for this presentation, that it works, but it's not for the novice surgeon. So with that, I want to thank all the organizers here and all of you for being a very, very, very attentive crowd.
Thank you, Dr. Udatta. Do we have any questions from the audience?
Kindly, all the delegates, kindly be seated. There are few announcements to be done. A few important announcements, kindly be in place.
Dr. Deepak, can
Before
we-
we start with the question and answer session, because all of you are going to leave this place before that. So the lunch is served in 4th floor, and but the only way that we can reach there is taking the lifts. There are 3 lifts on the left side as you exit, and 2 on the right side. And lunch is going to continue till 3 p.m. So there is no hurry. But the scientific session is going to start again at sharp 2. So please make yourselves comfortable, and there's a separate area for the faculty lunch. So do honor the faculty to reach their place. And second important thing is this hall is going to be split into hall A and hall B. So kindly take all your belongings along, because during the arrangements you might miss out on that. And there is one important thing again, after the inauguration in the evening, there is a special lecture by Dr. Benito Ramos. It is between 6:30 and 7:30 in the hall Neptune. So all of you are invited for that. Okay? It's not there on your regular schedule. It is between 6:30 and 7:30, and it's more useful for the surgeons. That's what I saw it on the abstract. Okay? So the lunch will be served in the 4th floor.
Thanks, Dr. Deepak. Do we have any questions for Dr. Udatta?
I can take the questions during the lunch
You
break. I think
during
let's not
lunch.
delay any
Right,
further.
I would like to request the chairpersons to kindly hand over a memento of appreciation to Dr. Udatta. The chairpersons kindly be on the stage to receive your certificates of appreciation from Dr. Rajiv Khosla, President ISOI. To Dr. P.S. Vimal. Yes, yes. Dammag ಮಾಡ್ತಾರೆ. Dr. Vibha Shetty. Thank you, sir. Thank you, ma'am. We'll start the session at sharp 2 o'clock. Kindly have your lunch and come back. Thank you.
We need to lunch. Morning breakfast also illa.